Thank you, Monique, for this kind introduction. And yes, when I was asked to give the lecture for Charles Boucher, I was really honored, but now I have the challenge to present a long story of our HIV-Q patient, the Düsseldorf patient, in 20 minutes. So let's start. These are my disclosures. I had some lectures, and I also attended some advisory boards. So when we talk about HIV-Q, we have to distinguish between a sterilizing cure and a functional cure. So when we talk about the sterilizing cure, it means the complete eradication of replication-competent viruses. And there are several approaches, of course, the stem cell transplantation, but there are also other approaches for getting to this cure, like gene editing, the latency reversal, block and log, and so on. This is not topic today. And in a functional cure, it just means that there is a sustained control of viral replication, and this is without any antiretroviral treatment. So just due to the immune responses, which is defined by the cytotoxic T lymphocytes, by the antibodies, and also by the NK cells. So one of the most challenging situation to analyze the persistence of HIV in the CD4 T cells is the different activation status of the CD4 T cells. So the majority of the CD4 T cells, which produce the majority of the plasma virus we see in our monitoring analysis, are the activated T cells, and they have a half-life of about 1 day. But there's another group of CD4 T cells. These are the productively infected CD4 T cells, and this is a really low population of this group, and they are also able to produce replication-competent viruses, but they have a really low proportion in it, and they have a half-life of about 14 days, and in the most situations, they have a resting phenotype. And the most important group of CD4 T cells are the so-called resting CD4 T cells. This is the stable reservoir. And actually, we do not know exactly the half-life of this group of cells. And to analyze this is one situation in the focus of research. To define the half-life of these resting CD4 T cells, there was made an analysis also published in 2003 by the group of Siliziano and colleagues. And what they did, they made a longitudinal analysis of about, I think it were 62 patients, which were sampled at several time points, about 7 years. And then they were made some viral outgrowth assays to look if there is any inducible replication-competent viruses in these cells. And what they have seen over time, that the frequency of inducible replication-competent provirus decreased. And so they made some modeling and so on, some statistical analysis, and they have shown that the half-life of these cells is about 44 months. And so they calculated that time to eradication is longer than 73 years, so this is no option to wait. So in the last 20 years, they made follow-up analysis, and what they have done, they didn't do any more the viral outgrowth assays because they were really, go over a long time and a lot of work in the lab, and there are some other difficulties with these analyses. I will tell you later. They made IPDA assays. They looked for intact proviral DNA, and there they have found that there wasn't a decrease over time. They have seen there was an increase of the intact proviruses they detected in those patients. And they have seen, or they speculated, this is due to cell proliferation of the infected CD4 T cells. So you see, to eradicate the resting CD4 T cells is really challenging. So there are only a few case reports on HIV cure, and I think the most of them you know. There's of course our Berlin patient from 2009 and the London patient which was published in 2019. And in this year, there were several reports, one published from a cured woman in New York, the so-called New York patient, which was already published last year at CROI, and also this year patient, the City of Hope patient, who was presented this year at CROI. But now coming to our patient, the Düsseldorf patient. The Düsseldorf patient is now 10 years after his stem cell transplantation and more than 4.5 years now after analytical treatment interruption. And until now, there's no viral rebound, and we haven't found any hints for immune responses to HIV replication competent viruses. So in more detail, the Düsseldorf patient is born in 1969. He's a male patient. He was diagnosed for HIV in January 2008, and he was started with antiretroviral treatment in October in 2010 with a combination with Truvada and Boucher. But in January 2011, he was diagnosed with an AML, and after chemotherapy, he had his first complete remission, but unfortunately, he had a relapse in September 2012. At this time point, we already analyzed the virus of the patient, and we have seen that the majority of the viral population we have found in the patient were CCF5 tropic. The tropism analysis were performed by next-generation sequencing, and of about more than 17,000 reads, you can see it here at the bottom, there were only 0.14% to be predicted as X4 tropic. And we thought, okay, this is not enough. We want to do some phenotypic analysis, and we selected some clones for the analysis in a phenotypic assay and sent it to Monique, and she performed the phenotypic co-receptor tropism analysis, and our results were confirmed. So we said, okay, CCF5 tropic virus population. So at this time point, we decided not only do classical stem cell transplantation, which mostly 10 out of 10 at HLA-matched donor. We also looked for a donor with a deletion in the CCF5 gene, the delta 32 deletion, which results in a truncated CCF5 enzyme, which is not able to be presented on the cell surface. So all homozygous people who have this mutation in the homozygous way, they are resistant to HIV for the CCF5 tropic viruses. After stem cell transplantation in February 2013, the patient got a relapse of AML in June, but he got 8 cycles of 5-azacitidine and 4 dynalymphocyte infusions, and so he got his 3rd complete remission. Here you can see it's really, really small. I think you can read, but this is the clinical course of the patient. You can see at the top, you can see the different time points from relapse, from stem cell transplantation, ATI, and below you can see the HIV proviral DNA, the plasma viral RNA, and at the bottom you also see the CD4 and CD8 cell counts. I just want to point out here that when you look at the time point of analytical treatment interruption is at the time point when there are no drugs more indicated, you can see there was no detection of any viral RNA or proviral DNA. And to exclude that the patient still takes any drugs, we also did some TDM analysis at 4 different time points, 3, 6, 9, and 12 months after stopping the treatment, and no drugs were detected. And what you also can see that there are, after treatment interruption, there were many many slides indicating the sampling of the patient. At the beginning, we sampled him twice a week, so it was really challenging also for the patient, but at the end, he was able to blood withdraw himself. Oh. Sorry, this way. Yes, okay, we didn't have found any proviral DNA. We haven't seen any viral RNA in blood. So this is not enough, because when we look at the HIV reservoir, we have to go into more detail. We have to go and look in the tissues. And this is what we did, because we have seen, it's also a publication which was published in 2010, that the HIV DNA concentration in tissues significantly increased compared to the PBMC, so to looking at the PBMCs is not enough. And therefore, we did some RNA and DNA scope analysis. These are in situ hybridization assays for viral RNA and DNA. And you can see on the left side the HIV positive control, and I don't know if you can see it, but there are some pink spots in there, which is a signal for viral RNA at the top and viral DNA at the bottom. Then we have analyzed the lymph node tissue of our patient. It was in month 51 after stem cell transplantation. It was before treatment interruption, and there we also find some signals. So he was still on treatment, but there we also find some cells which give a signal for viral RNA and DNA. So it was not in the way as the positive control. It was just above the threshold of the assay-specific cutoff for the negative control. So we didn't know what it means, but there was something okay. We looked further after analytical treatment interruption. It was 77 months after stem cell transplantation, and we got some biopsies of the patient from the duodenum and rectum. And there we also found some single signals in the duodenum indicated with the arrows, but none in the rectum. Okay, some signals in the tissues. What about the resting CD4 T cells? Where can we find them? This is a slide which was kindly provided by Björn Jensen, because I wanted to show it because it illustrates how difficult it is to find the cells which harbor the inducible viruses, which are really replication competent. Because there are several studies and publications that have shown that there is approximately only one CD4 T cell which harbors one inducible provirus in 1 million cells. Okay, how to find it? How can we measure the latent reservoir? There are several assays available you can use, or you can send your samples there. Classical analysis is to do the standard PCR analysis of the proviral DNA. Okay, so you have an information, but you have no information about which viruses are really replication competent. Is it only the rubbish, or is it really something that can replicate? Okay, then you can measure with functional assays. You can do the viral outgrowth assays, the quantitative viral outgrowth assays in cell culture, or you can do the mouse viral outgrowth assays, which is known to be more sensitive than the quantitative viral outgrowth. Okay, you can do that, but it's the data we actually see is that there is an underestimation of the true reservoir size. As when you really want the true size of the reservoir, you need more activation rounds for the CD4 T cells that the viruses get induced. So the hypothesis there was that to analyze the true size of the reservoir, you have to analyze the intact provirus by IPDA analysis. And therefore, to check this hypothesis, there was a big study performed by Simonetti and colleagues. They analyzed the CD4 T cells of 400 HIV-infected individuals for their provirus status in the reservoir by IPDA analysis. And what they have found is that there is only about 8%. Sorry, there's something flying. Sorry, there's only about. Oh no, back. there's only about 8% of intact provirus in these patients. And they also calculated the detection rates on the mean measurements they did here in the top. They looked for intact, they looked for deleted and hypermutated viruses. And they calculated that the detection rates for the IPDA are much higher compared to the viral outgrowth assays, as 1 per 1 million compared to 38 per 1 million resting CD4 T cells. Okay. We also did viral outgrowth assays with our patient, and you can see here at the top the timeline, and you can see the different outgrowth assays. We did the quantitative and also the mouse viral outgrowth assays with 2 different mouse lines with an immunosuppressive phenotype, And to sum it up, we have seen no signals. Everything was negative. We didn't find any plasma RNA. We didn't find any cellular DNA. And with the Q4, all showed negative results. So no detection of HIV anymore. So this is a really busy table. This is an overview about all HIV reservoir analysis we performed in these years. And we looked, of course, in peripheral blood. We looked in bone marrow, lymph node, gut tissue, and so on. And what we have to point out that all assays we performed were really, really good, because in total we had 119 negative controls, and there was only 1 positive droplet in the digital PCR. So I think this is a really good control. But nevertheless, when you look in more detail in this busy table, you see that there were some signals. You have seen that already in the in situ hybridization assays, some signals. We also found some signals in the digital droplet PCR. They were not high. The results were questionable, you know. We didn't know what it means. Is there really a replication possible or not? So we thought to check the immune responses, the cellular and the humoral immune responses, and what we have seen that there was a waning HIV-specific immune responses. We made a lot of immunologic analysis. Due to time, I cannot present everything. Just as example, we have seen here there was a decreasing and stable immune activation of the NK cells and the CD8 T cells. We have seen waning CD8 T cell response. We have seen in the immunoblood analysis waning HIV-1 specific antibodies over time. So independent of treatment interruption, we haven't seen any increase in any immune responses indicating or giving a hint for any replication activity in the field we cannot see in our analysis. So what are the similarities and what are the differences between the patients we want to learn? We want to learn what is necessary for an HIV cure. And at the beginning we thought, okay, maybe it's the irradiation, but you need more irradiation for the patients, for eradication. Oh, it's dark, for eradication of all the resting CD4 T cells. But at the end, we have just found one point. This is similar between the patients. All patients presented a 5-tropic virus at the time point of cell transplantation, and all patients were transplanted with an homozygous delta 32 donor. And this is what we can see at the moment. So in conclusion, lessons learned, of course, the examination of the reservoir is really challenging. These assays needed a lot of work, and you have to be very, very sensitive, but also the interpretation of the results. You always see some traces, and we don't know what it means. And to perform the immunological analysis may be helpful for the interpretation of the results, but there are still some questions open. So is it essential, the killing of the last remnant intact viral reservoir? Is it really essential? we don't know, probably important is the reduction of the viral reservoir by transplantation and so on. And to have the situation that you have a CCR5 mutated gene in the patient, so there is a resistance for infection of CCR5 tropic viruses. We think this is really important. Then to modify the host and in a CCR5 tropic background leads to the absence of the replication competent viruses, and this is maybe a sterilizing cure. So at the end, we just can say that an analytical treatment interruption is the only way to validate a long-term remission, because our assays are sensitive, but I don't think they are sensitive enough. So I think the story is going on now 10.5 years, and we will look further to our patient. And finally, I want to acknowledge all the patients who are involved in the analysis. And these are many people, and there are more people who worked in the labs to do all the assays. And of course, we want to thank our Düsseldorf patient, Mark Franke, for all his support. And yes, thank you very much for your attention.